Welcome to the latest episode of Open Access, Open Mic, the podcast with the APT Foundation. The APT Foundation is here to help employers, communities, and families care for people who may be living with opioid or other substance use disorders. Serving the Greater New Haven community through an evidence-based open access model. Get in touch with us to find out more at aptfoundation.org. On this episode of Open Access Open Mic, I'm joined by the APT Foundation President and CEO, Dr. Lynn Madden, and our special guest today is Dr. Rick Altice. Now, Dr. Altice is a professor of medicine and public health at Yale University School of Medicine. His research interests are focused on infectious diseases, including HIV, tuberculosis, and viral hepatitis, and substance use disorders. He is specifically interested in implementation science, including prevention, treatment, and behavioral intervention research activities. As a clinical epidemiologist and implementation science researcher, he has created novel programs for the treatment of HIV, viral hepatitis, tuberculosis, and substance use disorders in vulnerable populations. He is currently the principal investigator on numerous clinical investigations and training grants around the world, including studies in Ukraine, Central Asia, Malaysia, Peru, and the country of Georgia, and of course, the United States. Dr. Altice lectures nationally and internationally about HIV, viral hepatitis, tuberculosis, substance use, and the delivery and organization of healthcare services, including integrated healthcare. You have done and are doing an awful lot. Dr. Rick Altice, welcome to the podcast, Open Access, Open Mic.
Thanks for having me today.
So I'm Lynn Madden, as Claire said, and it is my great pleasure to welcome Dr. Altice here today, who is both a colleague and a friend. I've had the good fortune of being able to work with Dr. Altice in many parts of the world over the last decade or so. And I'm very excited to ask him today to kick off our conversation by telling us a little more about himself, his career to date, and how he really got interested in this work. Rick?
Sure. So, it goes back a long ways, but as an infectious diseases clinician, I was taking care of patients with HIV. And in Connecticut, HIV was really concentrated among people who inject drugs. And I really realized that I could not actually take care of my patients unless I learned to sort of think about the way that healthcare was delivered for people who inject drugs, and also to think about the treatment of substance use disorders, because that can be both preventive and help with engaging patients in treatment. So that has sort of resulted in a 40-year career of sort of thinking about those two things together and creating innovative ways to scale up both HIV treatment, hepatitis C, TB, and at the interface of substance use disorders.
So thank you for that. Rick, you're well aware of the open access model that APT Foundation has been pioneering and really has continued to develop here in New Haven across the last 15 years or so. Has that model influenced your international research at all, or your thinking about healthcare models?
Absolutely. One of the things that has been a struggle is that I've had the good fortune and perhaps the challenge of even introducing substance use disorder treatment in several countries. In Ukraine, 2004, methadone in Malaysia in 2005, and in a number of other settings. And one of the things that has always been a challenge is that many of these programs remain somewhat limited. They look like pilot studies for many years. And so the question is how can you open up those doors and increase access to treatment so that it's not just treating the individual, but really sort of thinking about population health, which is where the real benefits from addiction treatment happen. And so that sort of model of open access, of really opening up the door and letting people in and finding ways to creatively retain them, has been sort of really some ongoing work, certainly for the last 10 or 15 years, where, I've gotten to work with you, Lynn, to sort of think about those things in other settings that are really distinct from the U.S., but the challenges in so many ways are the same.
Absolutely. I too find that fascinating. Each location believes that its issues and problems are of access and stigma are so very unique. When in fact, if you have the opportunity, as we both have, to kind of travel a bit and listen to people, what we learn over and over again is that many of the difficulties are quite across the world are quite common. I know most of your work, Rick, is focused on the intersection, or much of your work is focused on the intersection of HIV and drug use, as you mentioned. Have you seen, or are there healthcare delivery models that you've seen in Europe, Asia, elsewhere that make it easier to treat opioid addiction and other substance use disorders?
Yeah, so I would just first of all point out that I think that there are so many different ways to think about treating, substance use disorders. And, if you sort of look around, it's really about, as you point out, if you open up access, you can open up access in so many ways. You can do it at an addiction treatment program. Some of the work that we've been doing more recently is thinking about how to deliver it in settings that where there might be reduced stigma, such as primary care settings. We've even done work here in Connecticut and elsewhere where we link addiction treatment to sort of reduce opportunities to reinforce stigma by using telehealth and doing it at syringe services programs. I would say that there's just so many different places. A lot of my work for many years has been in criminal justice. These are all sort of touch points where, our patients go. And any time that you can sort of identify and really effectively get them into treatment from the minute they walk in, that's an opportunity. And it's oftentimes a missed opportunity through what I would call the very complex referral system that gets in the way of many patients getting care. So, I sort of say, when my kids say that they're hungry and they want something to eat, I need to feed them now. And it should be the same way for treatment as far as I'm concerned.
That's
And I think
fascinating.
that those models, there are creative models that have really emerged because of necessity. And they have happened in many different places. And I don't think that there's an exact formula. I think all of those things combine together to create a patchwork quilt of treatment options is really the way to go.
Mhm. So the COVID pandemic showed us that the international epidemics can show up at our doorstep here in the US at any time. A lot of your work is funded by the United States government and NIH and National Institutes of Drug Abuse, et cetera. Can you talk about that concept in the context of your research? What about the relationship between HIV, AIDS, and the opioid use disorder? How is it important to look at this in context other than our own, and to think about the value that it brings to us here in the US as well?
Well, I think, being able to have the 30,000-foot view of the globe rather than just the US really helps you think about things. But one of the unifying themes around COVID was that it was a major disruption. It changed the way that we had to do things. And so, on one hand, as an infectious disease physician, I was really recommending that we reduce opportunities to transmit HIV. Reduce opportunities to reduce COVID transmission. And so that would mean keeping patients out of clinics if you can and do that safely. And also sort of reducing demands on them so that they're not embarking on public transportation or other ways to transmit and COVID throughout the community. So, there were many places around the world. They were somewhat different, but they used those same sort of principles around sort of reducing or mitigating community transmission. And it created opportunities to take a look at, how you might think about organizing treatment. And I think it was true in the US where, addiction treatment programs were asked to sort of relax their take home dosing. In Ukraine, it was really an extraordinary sort of scenario where they were asked to do that for as many patients as they could safely. And, as long as the clinicians who were really deathly afraid of giving patients take home dosing, I think that we've been frightened by many years of propaganda and other sorts of things that really people believe, which is not true, but they do believe that our patients need a maternal or paternal care around this and that they won't take care of themselves. But one of the things that was force majeure during COVID was that we had to give patients take home dosing and we had to come up with creative ways to support them during that stressful time period for them as well, which we could do through, telehealth and through conversations and take home dosing and screening them for ways that we thought that they were safe. And, even in published data, so, it's your real world observations, but in real published data, it really shows that in places that did that, they reduced the demands on patients, they reduced the demands on their time. If you're not seeing a patient for, 5 minutes every single day, 7 days a week, throughout the entire year, you're able to spend time doing other things such as counsel them or to talk to them on the phone or to keep in touch with them. And what the data have really shown is that by giving them take home dosing, relaxing those demands on them, patients did not overdose. They did not divert their medications. And places like Ukraine were able to really scale up their medications for opioid use disorder because they found a lot of free time. And so if you're really thinking about a public health benefit, this is the way to do that. And fortunately, even in the US, we've been able to sort of maintain some of that COVID guidance around keeping those patients on take home dosing, which is really sort of a sea change in terms of way as of thinking about patients. And I think that, while I wish that we would have gotten there quicker and that we didn't have to have the COVID pandemic, to learn that, we did learn from that. And we learned that we could do other things faster, better, and cheaper. And we really need to think about that.
So, infectious diseases and severe risk to public health, as you're pointing out, don't respect national borders. And as you and I talk about all the time, the policies that governments design and adopt don't always promote wellness or public health goals, although it may look like that is the intention on the surface. How has this paradox really played out in your career?
Well, the most recent thing that comes to mind, and I've been doing a lot of thinking about this, is the war in Ukraine. And, one of the things that happened is that, 9 million people were displaced. They became refugees in Europe. And, many of those patients were patients who were on addiction treatment. And unlike, let's say for HIV, where, well, you still don't want to miss medications for a few days, but if you miss your medications for opioid use disorder, you go into withdrawal and you feel sick and you feel awful. And the way that you might manage to, address that is to, find an opioid, oftentimes injecting it, and in order to not feel sick. I think none of us want to ever feel sick. And one of the things that we really thought about, even though we were focusing a lot of our time on sort of keeping people in Ukraine on treatment and maintaining those supply lines and getting clinicians to really take internally displaced patients, one of the things that was very clear is that certainly some people were getting out of the country. They were going to other sorts of settings. And in the case of HIV, many of them lost access to their medications, and we found that they developed viral resistance and their treatment options weren't as good. But one of the things that was so striking is that we began to review what was happening to people with opioid use disorder as they went to Poland or to Germany or to Moldova or any of these other sorts of places. And, you know, the policies that they thought that they had in place on the books really didn't really reflect the fact that they were taking people from Ukraine. And let me just give you a couple of examples. First of all, if you have to navigate a healthcare system, and even if you're doing it in your own country, it's not always so easy. But if you go and you're in another country and all of a sudden you're looking at a different alphabet, the Cyrillic alphabet doesn't look anything like, the Latin alphabet. So you've got a different language, you've got a different alphabet so that you can't even really distinguish that from a healthcare perspective. You're trying to go through policies, and even the restrictive policies. Many places in Europe had even more restrictive policies than they had in Ukraine. And so let's say, for instance, if you were a refugee and you were sort of placed in a remote country area, but the only place you can get methadone is in the addiction treatment setting in the large city that's 40 kilometers away. You can imagine you might have to, one, spend money to get back and forth to get there. You have to spend time every single day. And if you're having to care for your family or for anyone else, that's not really compatible with that. And so these borders, we have them there, I suppose, for, governmental reasons. But when it comes to treatment, it's really sort of a challenge, and things like war, really transcend that. I have colleagues who are on, let's say, methadone treatment, and they want to go to conferences. They're professionals. They're working in doing their work. And the real challenges they have is, they can't take a vacation in another country. They can't present at another conference unless they go through sort of special regulations, or they get to the other countries and the other countries can't absorb them because of their own sort of policies and structures. And so I think that we've got this sort of system that is designed to not help people succeed in their recovery.
That's a wonderful segue to this next question. And it may not be the first thing that comes to mind for most people in the United States about the war in Ukraine, but both you and I have been focused on this, and we've had colleagues and patients who have been severely affected by the war. How would you say the war in Ukraine has affected the clinical care being provided there, including people's ability to access methadone treatment?
Well, it's a mixed story, and it depends on where you are in the setting, within the country. That is, if you happen to be in a conflict area, you may have major disruptions to medications, and your doctors may do the best that they possibly can and give you 30 days supply and say, please go find a safe space. Not everybody can do that, because grandma who's 85 years old, who's living on the 11th floor, needs someone to take care of them. And so, there are some major disruptions that, happen in terms of supply. I will say that the country did a pretty good job of really trying to relax some of those standards to make sure that there was some compatibility with being able to continue to live your life. But, the other sorts of things that happen is that, you know, with medications like methadone that are so highly regulated, just even the transportation from settings, and if you have 6 million people who are internally displaced within your country, can put huge demands on clinics that are not prepared to have that many patients. The one thing that I did learn about this whole process is that we had been working on, really using a quality improvement strategy, Niatex, the one that Lynn used in the open access model, which has been so successful here in the US. But people were getting coaching, and they were getting support, and they were creating a collaborative community where they could communicate. And one of the things that happened, as a consequence of the war and many displaced patients, and having patients who weren't previously on treatment, who, really were very stressed out, and they all of a sudden wanted treatment, is it really required them to create different ways to do their work so that they could absorb those patients, not restrict access to treatment. And I will say parenthetically that while there was a sort of a disruption and a decrease in patients for a very short time, they actually ended up scaling up extremely fast. And the other thing that they had to do is there were several thousand patients who were getting private treatment, and they were getting their medication through pharmacies. And when the pharmacies just dried up in terms of medication, these patients who were in these privatized healthcare settings had to go somewhere. And the government opened up its doors. It wasn't always the easiest thing. Different people had different structures, but at least they were coached through ways to think about really not discontinuing, treatment. And, you know, one of the things that happens in war is many people retreat, and they go back to, let's say, protecting their patients and their sorts of own careers. But many of them, through coaching, decided to open up their doors. They massively scaled up and took new patients in ways that they did not think that they would able to do. I know that they were really grateful, and I think they should be really proud of the work that they did under, heroic circumstances. The other point that I think that's really important for those physicians to be able to do that work with, supportive coaching, was that they had a government that was intact. The government during the initial invasion had already moved westward, and they could have taken all of the money that they had to support the methadone and use it on defense. But they made a really important commitment to these patients to say, we will sustain that. And the World Health Organization and many other organizations, came to their rescue and said, we agree with you and we will support that. So they did a really heroic job of not only the government supporting it, our coaching supporting them through the process, and them creating a community. They were networked through WhatsApp and Viber. They communicated, they were able to create new systems and models of care, whereas, we're oftentimes restricted to, multiple, sort of releases of information and paperwork. And they just did the right thing. And I think that that's an important testament to what people can do whenever they're faced with such hardship.
Yeah, I couldn't agree with you more. I have been very impressed with the resilience of the healthcare system in Ukraine despite the war, which continues to this day, and it has massively affected nearly every aspect of the every region of Ukraine. One observation I would throw in there is just the absolute dedication that you referred to, Dr. Altice, the absolute dedication of these physicians and other care team members to their patients. And let's say what's important about that from my point of view is a illustration of the regard in which they hold each other as citizens, despite the fact that these are persons labeled as substance users and diagnosed as people who are substance users. I have not observed that same kind of dedication to caring for people with substance use disorders in other parts of the world that may have experienced disruptors like wars or natural disasters. So that's been very, very impressive. I would also just ask you to comment a little bit. One of the things I admire about you and your work is that you have taken the long view in many of the settings that you work in internationally. And what I mean by that is that you work with people on the ground over years. Comment on that a little bit about your approach and why you look at it that way.
Yeah, I'll definitely do that, but I want to just reflect back on what you just said about some of those commitments and an anecdote about that. So one of the things that has been so impressive is that, if you sort of think about the people who do addiction treatment, they're marginalized within their own community, right? So they are oftentimes they're saying, "Oh, those are the addiction treatment, doctors." I remember a time when my mom wanted to introduce me as a cardiologist because she didn't want to tell people that I do addiction treatment or I do HIV work. And so, your own parents can marginalize you in sort of really unusual ways. And, that was the landscape. And this sort of speaks to the long arc that Lynn that you're talking about. But that's where much of the community was when we first got started. And they developed a community, they created their expertise. And because of the really extraordinary work, they elevated themselves. We didn't do that. And so that sort of long arc, was there. And as an example of that, one of the things that happened during the war is there was a physician who headed up the program in Mariupol, which was completely decimated. And this is a guy who, with almost no time whatsoever, r- rallied his family. They got in a car, they made several different trips, and they barely got out of that area. And they made it to Poltava, and it was really stressful for him. He had a heart attack when he arrived in Poltava. And what was really extraordinary is those clinicians rallied around him. They helped him through the recovery and they employed him to continue to do that work. And so that kind of resilience sort of speaks to that because they had created a constituency within that setting and they were supportive of each other, which I thought was really, very sort of striking. And while they don't have sort of a professional a group to, like the American Society of Addiction Medicine or addiction psychiatrists, they don't have that sort of thing there, but they created that, which was, really important. And to get to your most recent question, Lynn, you talk about the sort of the taking the long arc of sort of viewing this work. One of the things that I have really been critical of researchers because that is, in addition to being a clinician, I am a researcher. And that is what I call the parachutists, the ones who are the colonialists who will drop in. They have the idea that the only thing that they want to do is how they want to do it. They drop into these settings, they do their studies, and they parachute out or they helicopter out. And what I find is that one is that doesn't result in a sustainable change. It doesn't result in people who actually will think kindly about the way that people come in and do work. And it really does not allow you to culturally understand what these things mean in these settings. And so even though I would say that the brain and addiction is the same in every single one of these settings in terms of the way you treat it, the cultural competencies of understanding what your constituents and your colleagues are thinking about is so absolutely important. And it also is the way that you sort of can think about doing things creatively and differently than you might have done elsewhere. And I will say that some of the ideas that I've learned from being in, sort of lower income settings. I was in Haiti many years ago and I saw these community outreach workers who had no licensed credentials whatsoever screening people and treating them for Malaysia. And that was 40 years ago, but it was at a time when, we didn't really think about the ideas of task shifting. And that idea is things that I've brought back to my own work here. And it's been things that we've been able to do in other settings. And as long as you give people sufficient training and they know where the guidelines are for them and when they need to sort of reach out to, someone else who is licensed, has been sort of a game changer in being able to do this kind of work, especially in low and middle income settings. But I would even say in the US, we talk about the first world and the third year world. Much of the work that I do, I call it the fourth world. We're taking care of third world patients in a first world setting. So if you add them together, you get four. And so that's the same sort of thing.
Absolutely.
That's spot on.
Absolutely.
It really is.
Yeah. So we're to you, I think, Claire.
Okie dokie. Incredible. Absolutely incredible. Sorry. Is substance use getting in the way of your ability to partake in activities you once enjoyed or maintain any aspect of daily life? Opioid or other substance use disorders can be treated safely and effectively. Reach out to your local treatment network through samhsa.gov/find treatment. That's samhsa.gov/find treatment to start medicine and begin your recovery. Brought to you by the aptfoundation.org. So there was a question that I was going to get Lynn to fire at you, but I'm going to do it anyway. So thinking about the research that you've done and that you're going to do, and the research that thinking about the research that you're both undertaking now, do you care to tease out any of your most recent findings? Spoiler alert.
Hard question.
Spoiler alert.
Yeah, there's a lot of really good stuff that, I think is really exciting. I think that the disruptors that we've seen from COVID applied to war, and we're finding that we expanded and we're able to sort of take advantage of those disruptors even with war to really sort of think and reframe how we, can do this work. There's increasing conflicts everywhere on the planet now, whether it's floods, whether it's fires, whether it's hurricanes, or whether it's frank war. And where those disruptions happen, we have to have ways to be able to operate. So I would say being able to shift and move on a dime has been one of the most important lessons in a lot of this work. We're doing some work in Central Asia. We're working in 3 countries, and each of them is really different. And the types of things that, that come your way during the process of your work has been really important. It's being adaptive. Many researchers work from a protocol perspective. Protocols don't work in implementation, and they don't necessarily work in real world. And so I think that the thing that has shifted for me is over the last several years, I've been able to shift from what I would think of as a very tight clinical trial and a protocol that may or may not have any applicability in these other settings. And so being able to sort of adapt and modify and change under those settings has been one of the things that I've been most excited about and most proud about in terms of the work. And Even if I shift back to something that my mom said to me, even before I went to college, she said, the most important thing you can do is make a difference. And I think that the work that we're doing in all of these places is truly making a difference, whether we're shifting the way that the delivery of HIV care is happening. We're using lessons from addiction treatment to shift the way that HIV care is being done in Peru, or with how do we reorganize the services for HIV in a way to reduce stigma by reducing interactions that can reinforce stigma. So all of it's interrelated. And, whether your area is addiction treatment or HIV or any of these other sorts of things, there are really important cross-cutting lessons that sort of you can move back and forth between them. And I've found that to be one of the major exciting parts of the work that we've been able to do.
And some of the things that I would tease out that we have been talking about lately really play off what Rick was just saying. And that is that, the idea that the government shapes healthcare is a really fundamentally important one that we brought up earlier in this conversation. But I also think that people, once they understand what their healthcare needs are, have the opportunity to influence the development of the system. And I'll give you an example of that. In Ukraine, as Rick mentioned, we saw the development of a private system of treatment for people who inject drugs who have opioid use disorder. There were private opportunities to receive methadone treatment that people had to pay for. And there was great concern that developed in the country among many of our partners around the fact that, perhaps these private programs didn't have good quality, et cetera, et cetera. And, necessity really is the mother of invention. They will rise if, in fact, they're not available to people who don't want to be sick and who don't want to die. And we undertook a small study to have a look at quality in these programs and just who is entering them. Right. And very preliminarily, what we can say is that the people who enter these private programs are endorsing fairly high symptoms of substance use. They are paying out of pocket, so you can assume that they have sources of income of one kind or another, and that they're getting about as well as their counterparts in the public system in about the same amount of time. So just think what you could do with that, right? How you could harness that kind of creativity on behalf of the community to really scale up treatment and create these very fruitful relationships between public methadone treatment programs in this example and private programs, and really give people who we might think of then as consumers a bit more in the way of choice around getting their needs met. So it's just been and I think, and Rick and I have been talking about this, I think you'll see this develop in other parts of the region that we've been working in. So we're pretty excited about that kind of idea and many ideas that have come out of this work.
And if I could build on that, one of the things that even if the benefits did not look as good as they did in the private clinics, that basically is an opportunity, right? And so rather than shut down these things that are scaling up on a population health basis, if you can show that it's not, working quite as well as you'd like, but it's working, that becomes an opportunity to intervene, whether it's through coaching or through process change or, any of these other sorts of things that you can do. And 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 I do think that those kinds of models are going to be the ones that are going to be most sustainable by having these sort of mixed picture of treatment options. Because, if everybody had to go out and buy a Cadillac, most of us would do without a car. But if we had a Cadillac and a Ford and a Hyundai and stuff like that with different kinds of things, we have choices and we get the sorts of things that we want. And, my sort of observation has been that when people get the type of thing that they think about and that they want, they just do much better with that. So I think that I would sort of see this as an opportunity as, rather than a concern that many people have had that these private systems just won't deliver quality care. I think that they are. I think that if there is room for improvement, it becomes an opportunity, and people need preferences.
Do you know, from a layperson, that's fascinating. My first thought goes to, okay, how does that sit in terms of affordability? So I'm hearing the haves and the have-nots potentially. How does private treatment, if you like, in somewhere like Ukraine compared to other countries that you've researched in?
Well, the private treatments require that a person, does have resources. It's not going to be for everyone. So you've got to start out with some money. But let's just say you're an employed person, you're a professor at Yale, and you have a substance use disorder and you can afford to go out and buy your buprenorphine. That becomes an option where you can go get treatment. You can get it in the type of place that might be more comfortable for you.
Hmm.
And as long as you're able to, support that and to stay engaged in that, you're likely to do well. There will be people who will choose that and their opportunities may not be consistent. In other words, employment may not be that. So there does need to be a safety net. So you need to be able to have a way that people can move back and forth in between the systems for the people that are in the middle
Yeah,
zone, if you will.
absolutely.
And so, that's why I don't think it can be just one or the other. Otherwise, people will have major disruptions. But one of the things that you can certainly learn from that is how do you come up with ways to safely transition people between programs whenever they're unable to sort of sustain that from their own efforts.
Mm.
I mean, one of the reasons why people may choose that kind of system is they do need to work. They don't have the luxury of coming between 9 and 10 o'clock in the morning in the middle of their workday to
Mhm.
get treatment. And so, we do need these alternative models. And I mean, there's still things to fix about it, but boy, take advantage of what's there and think of it as a population health benefit.
Absolutely.
I was just going to say that as a carry on to Rick's last point there, the reality is from a population health perspective, the people who get evidence based treatment in this example of a private market for medicines for opioid use disorder are actually benefiting public health as well as their own health. Right. So over time, despite the fact that that private market isn't available to everyone because of resource inequities, right? The public market has the opportunity to learn, why are people going to this other clinic? Oh, maybe we can adopt that characteristic
Mm.
in our program. And everyone who gets treatment is making a pro-social decision that protects the larger public health,
Yeah.
which is what we're all after,
Yeah.
right? I mean, I think that people who use substances in general do not get much credit for making pro-social decisions, but entering treatment is a pro-social decision.
Mm.
And just to put some numbers on this, in Ukraine, we've got pretty good numbers for the people who are in governmental clinics. We've sort of scaled up from about 7,800 to 21,000 people or so over the time period that we've been doing that work. But the people who are on the private treatment program, which hasn't really been available except for starting in late 2016, and these are undercounted. These are only the people who are willing to report.
Mm.
There's over 10,000 people on that treatment. So roughly a third of the people who are getting the public health benefit are happening in this alternative system. And I would probably say that it might even be double that. It's just only a handful of clinics are reporting it, but there is a privatized system there that is certainly a little bit under the radar, but it is providing some kind of benefit and, potentially almost the same amount of scale up.
That's incredible. All right. Last couple of questions from me, and then I will let you get on with your day, I promise. So, when you look back over your career, just listening to you, you have experienced some of the most remarkable moments in time: the HIV epidemic, the opioid crisis, for example. With that in mind, what has been your proudest achievement or most memorable success story in your career to date?
So my proudest achievement has nothing to do with my work. It's having two beautiful twins. And so in a family, that's my proudest achievement overall. I would say that my proudest professional achievement is being able to really create meaningful relationships with colleagues across many different settings in the world and helping them, by working together, make a difference. Going back to what my mom said many years ago, it's important to make a difference. It's important, I think, at least it has been for me to not do this alone. This is not work that is done as an island. It's work that is done through collaboration, through multidisciplinary teams. And my own sort of elevation has only happened because I've been able to help other people elevate and, you sort of all rise together. So that's my biggest achievement, are these sort of longstanding, important, relationships that have only gotten, better. So much so that, some of my colleagues want to give me a sheep's head as a thank you. I mean, it's
Okay, I need to know. I need to know everything about the sheep's
Well,
head.
I can tell you a little bit about that. As you know, Dr. Altice and I have been working in Central Asia, in Kazakhstan, Kyrgyzstan, and Tajikistan for the last couple of years together. And last year in Kazakhstan, which was our first kickoff meeting of a new grant that we are co-running, and we were presented with a sheep's head as the guests of honor. This amazing, and it's like literally a sheep's head, right? Boiled in this particular case. And the various bits of it from a cultural perspective are chopped up and given to people in the room based on kind of honor rank. Dr. Altice swallowed the eyeball that year.
Good man.
Good man.
Good man.
It was
Good
given
man.
to me, and he saved me. And then this year in Kyrgyzstan, in Bishkek, just a couple of weeks ago, similarly at a lovely dinner, we were presented with a sheep's head. And once again, our fearless leader rose to the occasion. There is photographic evidence,
Rick.
and he ate the eyeball. So
Rick.
now he's truly all-seeing, Claire.
Very good. I need to see this photographic evidence. I think that should accompany this podcast. That is incredible.
I will send it to you, the head itself, and then, our contemplation of it.
I would love to see that. I would love to see it. Last question, if I may, and I'm asking you to be a bit cheeky, I'll be honest with you. And it's a question for both of you, this one. If you could rip up the rule books and how things are done, and the norm, if you like, or make sweeping changes as to how we as a society tackle substance abuse, what would you do? I give you free rein, whatever you want. What's holding back your incredible work?
So from my perspective, I think historical legacy is what gets in the way. People believe what they believe based upon, mountains of old information and old ways of thinking. And what doesn't happen and what needs to happen is that it really should be focused on a sort of an achievable goal. In other words, to get as many people onto treatment who need it as you possibly can. And if you are goal focused rather than the sort of the rule based focus, in other words, we often hear we can't do this because all of those sorts of things. That's what gets in the way. So the way that I would do that is I would try to remove that kind of thinking and just to sort of think about it as, I hate to think about it in terms of what is so heinous like the Manhattan Project and, the creation of the atomic bomb, but really focused on a goal, something that is really important in terms of achieving that and coming up with every idea that you possibly can in order to sort of make that happen. And that's what I would change is to be very Manhattan Project oriented with addressing the epidemic, as opposed to all of these sorts of things that people put as a reason for why things don't get done. I really don't want to hear explanations anymore. I want to hear outcomes.
What about yourself,
As
Lynn?
for me, yeah, I think what I dream about actually is that we could really think about substance use disorders as chronic illnesses, right? And what I mean by that is in the normal chronic illness kind of universe of treatment and social caring, we center the person who has whatever illness we're talking about, heart disease, diabetes, COPD, and we care about that person. We don't stigmatize them because they've developed these illnesses. Stigma is highly, highly responsible for these difficult rule structures that Rick was just alluding to, and for the lack of funding in many cases that it would take to really care for people. But if we could just think about teaching people what they need to know to take care of themselves, let them into treatment, stop restricting them from coming into care, let them be their own best advocates, trust them to actually care for themselves. Right. So when you crash, if you happen to have diabetes and your glucose levels crash, we help you. right? We don't tell you, leave my emergency department and, stop eating cake. We give you an IV and call your doctor. I mean, we have an ethic of caring for people and centering that individual that so far has not really permeated clinical, medical, social care regarding persons who have substance use issues.
I can't think of a better way of ending the podcast. I feel passionately about the work that you guys do, as you know, and we're never going to get a better soundbite than that. So thank you so, so much. I cannot thank you enough. To find out more information about what the APT Foundation do, check out the website, which is aptfoundation.org. I'm also going to put links to both Lynn and to Rick in the show notes of this. Find out more, educate yourself, and guys, just keep trying to fight the good fight.
Rick, thank you so much. Rick is a perfect talking head. Ask him a question, he'll give you an answer. I love it.
Listen, he eats eyeballs as well. I mean, the man is a living legend at this point.
I don't tell you where I think he can see from as a result, but the truth is...
I was going to say, they tell me that I'm all seeing now.
Guys, thank you so much for a fantastic podcast and being a part of Open Access, Open Mic, the podcast for the APT Foundation. Thank you.
Claire, thank you. Take care.
Thank you so much. Good talking to everybody.
Thank you, Rick.
Thank you for taking the time to listen to this episode of Open Access, Open Mic with the APT Foundation. If you have enjoyed this episode and want to listen to more, search Open Access, Open Mic wherever you get your podcasts from. A special mention to Hancock Pharmacy, who have been serving the Connecticut public since 1959. The APT Foundation values their help in serving our New Haven area clients. Their Long Wharf location provides medications for treatment of substance use disorders by prescription from our primary care doctors, who are also trained in addiction medicine. Visit HancockLongWharf.com. This podcast was created and produced by Red Rock Branding. redrockbranding.com.